Hello, I'm Dr. Maria Corcorran from the University of Washington. In this Hepatitis C Online mini lecture, I will review some frequently asked questions in hepatitis C treatment and management. The first question we'll review is, should a genotype be routinely obtained prior to hepatitis C treatment? In the days of interferon-based therapies and first-generation oral therapies, genotypes used to be a cornerstone of the hepatitis C pre-treatment assessment. However, genotypes are no longer routinely performed and no longer recommended as part of the simplified treatment algorithm, given the availability of highly effective pan-genotypic regimens, which include glecaprevir/pibrentasvir and sofosbuvir/velpatasvir. There are, however, select situations in which a genotype is needed to make the optimal choice of direct-acting antiviral treatment, either due to the possibility of underlying resistance-associated substitutions that affect cure rates, due to better treatment outcomes with the addition of ribavirin, or due to the use of a non-pangenotypic regimen. These scenarios include, number 1, anticipated use of sofosbuvir/velpatasvir in patients with compensated cirrhosis, or anticipated use of this regimen in patients with prior interferon experience, as resistance testing is needed in this situation prior to treatment of patients with genotype 3. Number 2, in settings of prior sofosbuvir or multiple DAA treatment failures and cirrhosis, as the addition of ribavirin or a longer duration of treatment may be needed in select genotypes. Number 3, anticipated use of a non-pangenotypic regimen. And number 4, when trying to determine persistent infection versus reinfection in patients with prior baseline genotyping. The second question we'll evaluate is, should hepatitis C resistance testing be obtained prior to treatment? Hepatitis C is an RNA virus that replicates rapidly, and as such, replication errors are common. However, most replication errors have no impact on treatment efficacy and are therefore of limited clinical significance. In select situations, however, resistance-associated substitutions, or RASs, can affect the response to direct-acting antivirals, specifically with NS5A inhibitors when used to treat genotype 1A and genotype 3. However, even when present, drug-specific resistance-associated substitutions must be present in at least 15% of circulating virus to impact treatment efficacy. Resistance testing is most important clinically when the results would modify management by impacting the duration of therapy and/or the inclusion of ribavirin to the regimen, or result in the selection of an alternative therapy. In the Phase 3 ASTRA-3 trial, which evaluated the efficacy of sofosbuvir/velpatasvir for 12 weeks versus sofosbuvir/ribavirin for 24 weeks in patients with genotype 3, the presence of a Y93H mutation decreased SVR rates from 97 to 84% amongst those who received sofosbuvir/velpatasvir. This was most impactful in patients with cirrhosis and in those with prior interferon-based treatment, and subsequently led to the recommendations to obtain baseline NS5A resistance testing in genotype 3 treatment-naive patients with cirrhosis and genotype 3 treatment-experienced patients, mainly referring to interferon experience here, with and without cirrhosis prior to the use of sofosbuvir/velpatasvir. There are also recommendations for NS5A resistance testing in select scenarios prior to use of ladipasvir/sofosbuvir and elbasvir/grazoprevir in patients with genotype 1A. However, these are less relevant to everyday practice given the limited use of these drugs in the era of pangenotypic antivirals. It should be noted that clinically significant resistance to glecaprevir/pibrentasvir is quite rare. Our next question is, can direct-acting antivirals be used during pregnancy? In 2021, there were 16,923 births to mothers with hepatitis C infection in the United States. However, there were only 199 cases of perinatal hepatitis C transmission reported to CDC, which is likely a gross underestimate, as studies estimate that approximately 6% of births to hepatitis C viremic mothers result in hepatitis C transmission to the baby. While there are no large-scale trials on the safety and efficacy of direct-acting antivirals during pregnancy or breastfeeding, there is accumulating evidence from very small studies that DAAs, particularly sofosbuvir-based regimens, are likely safe and effective during pregnancy. Because of these small studies, and because pregnancy can be a time when many women are more engaged in care and have health coverage, the AASLD and IDSA guidance states that treatment can be considered during pregnancy on an individual basis after a patient-physician discussion about the potential risks and benefits. It should be noted that ribavirin is known to be teratogenic, and this drug should never be used in a pregnant patient. I'd like to highlight some of the data that exists on the use of DAAs in pregnancy. In a phase 1 trial of 9 women with hepatitis C who received ledipasvir/sofosbuvir during pregnancy, treatment was found to be safe and effective, with 100% of participants achieving an SVR12 and no cases of perinatal transmission. Secondly, in a prospective observational study from India, 26 treatment-naive pregnant women without cirrhosis were given ledipasvir/sofosbuvir after the first trimester of pregnancy. All of these individuals achieved an SVR12, and none of the infants had congenital malformations or detectable hepatitis C RNA at 6 months of age. Similarly, in an ongoing study of 50 women who initiated on sofosbuvir/velpatasvir between 20 and 30 weeks gestation, there have been no cases of perinatal transmission to date amongst 26 infants, and 100% of women who have completed treatment and attended their SVR12 visits have been cured. While gastrointestinal side effects, including nausea, vomiting, and GERD, have been common amongst mothers, there have been no related serious adverse events in mothers or babies. The next question we'll review is, what are the management recommendations for patients with incomplete adherence to DAAs? Incomplete adherence to DAAs is common, and while short periods of non-adherence are very unlikely to affect treatment response, longer periods of non-adherence can lead to virologic failure. There are limited data on adherence thresholds under which DAA efficacy is substantially reduced. However, what data do exist suggests that DAAs are relatively forgiving. In an international open-label, single-arm study of 12 weeks of sofosbuvir/velpatasvir for persons with recent injection drug use, 97% completed treatment, although 88% missed at least one dose, and 32% were less than 90% adherent. Episodes of non-adherence lasting 1 to 2 days occurred in 61% of participants, whereas episodes of non-adherence lasting 3 to 6 days occurred in 17% of participants, and episodes greater than or equal to 7 days of non-adherence occurred in 11% of participants. Despite relatively frequent non-adherence in this study, SVR12 was achieved in 94% of individuals with less than 90% adherence, as well as 94% of individuals with greater than 90% adherence. Similarly, in a retrospective review of patients registered in a web-based regional Italian hepatitis C treatment database, 99% of individuals who received at least 4 weeks of treatment achieved SVR12 versus 50% of those who took less than 4 weeks, and this was among people without cirrhosis. Among those with cirrhosis in this study, 95% of those who completed at least 8 weeks of therapy achieved SVR12 compared to 83% of those who took less than 8 weeks. Treatment varied across this retrospective analysis, with 24% of patients receiving ledipasvir/sofosbuvir, 19% receiving sofosbuvir/decladisvir, and 14% receiving sofosbuvir/velpatasvir. The AASLD/IDSA hepatitis C guidance addresses the important issue of incomplete adherence and has developed recommendations to help guide clinicians. These recommendations are specific to whether the interruption in treatment occurred before the person received 28 days of DAA therapy or whether it occurred after they received 28 days of DAA therapy. For individuals who experience an interruption in therapy of 7 days or less within the first 28 days of treatment, the recommendation is to restart DAA therapy immediately and complete the originally planned treatment course. For individuals who experience a treatment interruption of 8 days or greater within the first 28 days of therapy, the recommendation is to restart DAA therapy immediately and get a hepatitis C RNA test as soon as possible, preferably at the same time as restarting therapy. If the hepatitis C RNA test is negative, then the patient can complete their originally planned DAA treatment course, although those with genotype 3 infection and/or those with compensated cirrhosis are recommended to extend their treatment duration by 4 weeks. This means that if an individual was planning to complete 8 weeks of treatment, they would now complete 12 weeks of treatment in total. Similarly, if the hepatitis C RNA is positive or not obtained, treatment should be extended by 4 weeks. In patients who experience treatment interruptions after receiving at least 28 days of DAA therapy, management again depends on the duration of treatment interruption. For those who miss 7 or fewer days, the recommendation is to restart therapy immediately and complete the planned treatment course. In patients who miss 8 to 20 consecutive days, the recommendation is to restart therapy immediately and obtain an RNA as soon as possible, ideally concurrently with restarting treatment. If the hepatitis C RNA is negative, most patients can complete their originally planned DAA treatment course. However, those with genotype 3 and/or compensated cirrhosis should extend their treatment course by 4 weeks. If the hepatitis C RNA is positive in this scenario, patients should stop their current DAA treatment course and proceed with retreatment as outlined in the retreatment section of the AASLD IDSA guidance. Similarly, if an individual has missed 21 days or more, then they should not restart therapy and instead they should be assessed for SVR12. If an SVR12 is not achieved, they should be retreated according to AASLD IDSA guidance. For our final question, we'll evaluate if patients with cirrhosis who achieve SVR still need screening for hepatocellular carcinoma. Hepatocellular carcinoma, or HCC screening, in patients at elevated risk has been shown to lead to earlier diagnosis of HCC and more favorable outcomes. The graph on this slide shows the outcomes of a study evaluating HCC screening among 18,816 patients aged 35 to 59 with hepatitis B virus infection. In this study, participants were randomly assigned to screening versus no screening for HCC. Screening procedures included a liver ultrasound and serum AFP measurement every 6 months. There were 86 cases of HCC in the screening group and 67 in the control group. 32 people died from HCC in the screening group versus 54 in the control group, and the HCC mortality rate was significantly lower in the screened group than in controls, suggesting a benefit to identifying and treating HCC early. Given the proven benefit of HCC screening, collectively the AASLD recommends HCC surveillance in all adults with cirrhosis, given a pooled estimated HCC incidence rate of 1% per year. Screening should be done with a hepatic ultrasound and serum AFP every 6 months. Although successful antiviral therapy for hepatitis C significantly reduces the risk of hepatocellular carcinoma, those with underlying cirrhosis continue to experience ongoing risk for HCC. As an example of this, in a large VA study among patients with hepatitis C and cirrhosis, the annual risk of HCC decreased from 3.8% per year in the first year after SVR to 2.4% per year by the 4th year after SVR, but this remained above the 1% per year threshold set by the AASLD. Because of this, AASLD currently recommends continuing HCC screening indefinitely in patients with hepatitis C cirrhosis, even after achieving SVR12. To learn more about hepatitis C, please check out our online hepatitis C curriculum, which contains a variety of lessons, cases, and slides to reinforce your knowledge. Thanks for joining me today.
The production of this Hepatitis C online mini-lecture was supported by a cooperative agreement from the Centers for Disease Control and Prevention, CDC, RFA, PS 212105. This project is led by the University of Washington Infectious Diseases Education and Assessment Program.